Our next speaker is Dr. Ardesheer Talati, who is a neuroscientist and a psychiatric epidemiologist. He's a professor of clinical neurobiology in the Department of Psychiatry at Columbia University Irving Medical Center and New York State Psychiatric Institute in New York. Welcome.
Hello, am I audible? Well, the advantage of following the talk and being the second speaker is a lot of the introduction has been done for me. The bad part is I have to follow your talk, which is a tall order. So thank you, Dr. Chambers, for inviting me, and thank all of you for coming. I'm excited to be part of it. Do I just press here? How do I move ahead? Oh. I don't have any disclosures. So my talk really follows Dr. Oberlander's, and he really laid out the current state of the field and the effects of SSRI exposure on a range of outcomes. His talk focused predominantly on the outcome part of the story. I'm going to delve in a little bit further into the exposure side, and specifically one thing that I think is key, and also Dr. Oberlander alluded to, which is depression and SSRI treatment, methodologically and clinically, are not two distinct entities that can simply be plugged into a model and controlled for. They're inherently interrelated. And I'm going to be talking about two general areas of research we did to try and disentangle these factors from each other. In the first, I'm going to talk about population-level data, and then I'm going to zero in on some of our birth cohort data. And the birth cohort data is a much smaller circle because they're much smaller by necessity. But what we lose in power, we gain a little bit in terms of temporal granularity of the data. Okay? Now, Dr. Oberlander is a pediatrician. The following speaker is an OBGYN. I'm neither. So I'm a neuroscientist, and my entree into the field was from a neuroscientific perspective, and especially this thing called a serotonin paradox that had been observed in preclinical studies where, and Dr. Oberlander referred to the work by Jay Gingrich, etc., where in adulthood, if you give an SSRI to a mouse, you see a reduction in depression-like and anxiety-like behaviors, which is consistent with what you'd expect, given what the medication is supposed to do. But if you give the same medication in early gestation, you see almost a flip. You see an increase. And what they found is this is a very specific serotonin SSRI effect. If they gave non-SSRI medications, they didn't see this effect. And it also wasn't just a behavioral effect. They also saw abnormalities in neuronal connectivity, arborization, mostly in the limbic regions of the brain. But the million-dollar question, of course, is this really relevant to human populations? Because in animal models, the alternative to giving an SSRI is simply not giving an SSRI. But in the real-world situation where it actually matters, the alternative to giving an SSRI would be leaving the maternal illness untreated. And we know from a number of studies that maternal depression and distress also have a significant impact on fetal development through inflammation, stress, sleep, a number of mechanisms. And that further increases the likelihood for maternal postnatal depression, which then has its own cascade of effects on the offspring. So already the word confounders and mediators should be sort of swimming through your mind if they haven't already. So the really it's a seesaw effect, and the real question is not are SSRIs good or bad or safe or not safe, but what are the relative impacts of exposure to the medication versus exposure to the illness, and then coupled on that to the mother and to the child, right? There are two compartments to the story. So I'm going to start off with a little bit of population data. I'm going in the reverse order as you. And I'm going to show representative examples from one of our Danish cohorts, but we've now replicated in a number of other cohorts, including in the US with Mayo Clinic data, and Dr. Oberlander and others have also replicated this. And then I'll talk about the birth cohort. So how many people are familiar with the Scandinavian registry systems? Okay, one is, great. 2, 3, 4. Okay, so very briefly, so in all the Nordic countries, healthcare is free and centralized. What that means is everyone has the equivalent of a social security number, and then you go to one of your clinics, and the data are recorded in these registries, be it a birth registry, a population registry, a death registry, a medication registry. But because they're linked by IDs, you could create a cohort of the desired variables that reflect the information you want, and it's complete for the population. So there's absolutely zero selection bias, right? It's everyone. And you could also link mother and child pairs. So if you want to study the effect of prenatal exposures, the obvious thing to do is you find pregnancies within a defined period, and we looked for this study between 97 and 2012, and we defined all the exposed pregnancies. And then we first got an unexposed comparison group, but as you would expect, that's a gamish of everything. So then we used a number of propensity score approaches I could talk about later to whittle it down to the best comparison group, which was essentially moms who were unexposed but comparable to the mother who were exposed on all other characteristics. For ease, I'm going to show you a sort of an omnibus outcome similar to what Dr. Oberlander talked about. We'll call it internalizing, which includes depression, anxiety, adjustment disorders, and the child's own prescription for an antidepressant medication, which is a proxy for at least moderate depression. We did see each of these separately as well, but I'll show you. So if you look at the raw findings, you see the orange is the exposed, the blue is the adjusted unexposed, and you see once you start hitting age 10, you see a fairly sizable increase, and this is statistically significant. So the first thing you might say, oops, this is not good. Then we try to break it apart using, as bet, the epidemiological tools we had in our arsenal. You can ignore this. So this just shows the hazard ratio for the model I showed you. So any number above 1 means it's a risk effect of SSRI, below 1 would suggest a protective effect, right? So you're seeing what looks like a risk effect. This just shows you some more demographics. It's slightly higher, but still similar in boys than girls, and you see more variation in first trimester effects, which probably reflects that it's also a more heterogeneous group of women who intended to take the medication versus those who intended to stop when pregnancy, etc. We also did a sub-analysis looking at just the mothers with a documented psychiatric disorder. And you still see a little bit of an effect. Then we looked at a subset of moms only who had used the antidepressant compared to an analogous group that had used medications before pregnancy but quit at least 3 months prior. So the goal here was to create a comparison group that was somewhat defined by the indication, right? So in every case here, there was an indication to get an SSRI. And here you see there's still an effect, but it's significantly reduced. So you see about half at least is accounted for by this indication. We then looked at two other models. One is we rationaled that if there is a pure in utero effect, what you would expect that maternal prenatal use should obviously be associated with your outcome. But if the mom only used it after pregnancy but not during, and I'm excluding breastfeeding here, then you shouldn't see the effect. And certainly a father using it during the corresponding pregnancy period should have no effect whatsoever. If, on the other hand, it's what Dr. Oberlander was calling the proxy or the hitchhiker, then you might see a different story where you would expect that perhaps maternal postnatal use or paternal use might also have some of the same effects, right? And we actually see effects with both. So the father's use and the mother's use after pregnancy in the absence of during pregnancy were also associated with fairly reasonably sized effects. So based on just this part of the story, you would be more inclined to lean towards the proxy model, okay? Now, what we have in these registry data are very good information on exposures to medications. What we don't have is granular information on depression. You're lucky if you get a depression code, but even then, sometimes if the women are treated by their primary care physician, they may give the SSRI, but when you're coming for other conditions in pregnancy that are more important to the OBGYN at the time, they may not even code the depression. So we said, let's look at this more granularly. How much time do I have left? So I'm about half done? Oh, good. So what we did is we started a birth cohort in Quebec. It's called the MPRINT cohort in 2019. And to understand this, what we did is we went to an OBGYN clinic and we recruited about 450 women using criteria to classify them as SSRI exposed, depression exposed but not SSRI exposed, and then control. But this is a fairly coarse characterization. So what we then did is every month we completed PHQ, anxiety measures, stress measures on the moms to get a more granular take. And then at the end of the interview, at the end of the pregnancy, we did a formal DSM-based diagnosis to get a fuller classification of psychopathology. And then what we did is at the end of pregnancy, when the baby was born, we reclassified the women, right, into these two groups to see how much overlap and non-overlap. And in the data I'm going to show you, it's the latter group that I want to use because we think that's the more reliable measure. And then once the babies were born, we did an MRI and EEG scan at 2 to 4 weeks, which I'm not going to show you. And then we did a few independent behavior observations at 6 to 12 months, which we're repeating at 24 months, and then did cognitive assessments at 24 months. The nice advantage of both of these is that these are independently observed behaviors. So the big issue, which is when you have maternal reports, it's not that they're not valid, but the moms who are more depressed or distressed may either have children who they view as having some of the same problems. So this doesn't solve every problem, but it takes out the maternal rating bias. So I'm going to just show you a snippet of data. So for our 6-month outcomes, we looked at 2 tasks. I don't know how many of you are familiar with the laboratory assessment battery, but it's where you have a task that the child does, and it's coded, it's recorded, and then an independent coder rates it based on predefined metrics. So we had a task called the peekaboo task, where someone comes in and does a traditional peekaboo, and we measure things like to what extent, how quickly, etc. the baby is laughing. And then an arm restraint where the arms are gently restrained, and then a new toy is introduced, and we look at how much the child is interested in focusing on the new toy versus the mom, and the latency it takes to whine to get there. We didn't find any results with the peekaboo, but we found some interesting preliminary results with the arm restraint in the opposite direction of what we expected. The SSRI babies at 6 months had lower facial anger and vocal distress. Now, you could argue, and we could discuss this in the discussion period, that means they were better off, or is it a reduced reactivity in general? That is, it's not the negative part, but it's just that they are less reactive in general. We wanted to check whether this, as Dr. Oberlander said, a lot of the SSRI results emerge early and then fade out over time. And we want to see if these are then reproduced at 24 months. The bad news is we don't have it because the coding has taken a while. So if you invite me in a future year, maybe we will. But we did look at some other 24-month outcomes. We looked at the Baileys, which is sort of an overall measure of infant development. And we looked at 3 measures, cognitive, language, and motor. And overall, you see no main effect. And in no group is the SSRI group, in no condition is the SSRI group worse off. You do see a separate depression-related effect where the mothers whose children were depressed, the mothers who were depressed, their children had less language in both the receptive and the verbalization part. But guess what? The moment we accounted for postnatal depression, that finding also went away. Okay? So we've talking about depressive symptoms now. But remember, I told you that we looked at measures across the 24-month period. So we said, how are they distributed across the 3 groups? Thinking that the depressed group will be very high, the control group will be very low, and the SSRI group will hopefully slip. This is what we found. It's a huge, huge mixture. Now, one additional caveat I should give you is these are people we recruited from OBGYN clinics. They were not from psychiatric clinics. And we also excluded people with severe psychopathology. So these are what you would call mild to moderate garden variety depression rather than severe depression. So that might also explain some of the results, but we didn't see any identifiable patterns. The same was with anxiety. So we then said, rather than use these existing metrics, what if we used data-driven methods and tried to see if these natural variations aligned into something that reflects our 3 groups. And we did find 3 groups. You could see there's like a low green group, which is sort of low. And then you see 2 higher groups, one where they start off higher and then they get a little better, and then one that's maybe gets slightly worse and then gets better. But these did not align well with our study groups. So the control group in green essentially tells you that most of what we're classifying as controls indeed were in the low column. But we found almost no separation between the depression and the SSRI group. If you look at the second and the third pie chart, see the red is the SSRI, the red is the depression. Oh, no, the second row is the depression. And you see that they map on fairly equally across these groups, right? And we see something similar for anxiety. So the bottom line with this part of the story is that the individual variation is far outweighing what we are classifying as the group variation. Now, how much time do I have now? 5 minutes? Okay, so I'm going to have the luxury of a quick detour. And everything I've been talking about is related to the brain, but the body doesn't stop at the neck, right? And we know that 90% of the serotonin or higher actually is in the gut, not in the brain. And just as we modeled our human studies after preclinical work, we took a similar approach here where our colleagues had found that if you genetically alter the serotonin system, you get a reduction in total GI and specifically colonic transit time. So the red bar is higher, saying that in the genetically altered part, you see it takes more time for the colon to clear. And you saw a similar thing with an SSRI administration, where the red is the fluoxetine exposed, where you see it's increased compared to the blue control. And then if you give a reversal through ibocerod, then you see that that effect is reduced. So yet again, is this relevant to human populations? Some studies had shown an effect, but it was in small samples, and they hadn't really controlled for maternal depression. So what we said, let's go back to our population data. This is the Danish data I told you about. And we sort of repeated the exposure level of the model with one difference. We said that since the former users, those who quit before pregnancy, are a more sensitive control group, we started off using that as our primary group, okay? And what you see, so these are now the hazard ratios and trends over the first 15 years of life. Here you do see a significant separation between the SSRI group and the control group. It's specific to constipation. You don't see it for other GI-related disorders such as abdominal pain or nausea, vomiting. And here, I'll just rush you through it. When you look at all the controls, the finding sustains. And with paternal SSRI, you see a little bit of a hint, but nowhere near like what you were seeing for the depression outcomes. We then replicate it in another data set, which I'm going to skip over to save time. So what are our take-home findings? And you'll see that they align really well with Dr. Oberlander's. So from our population data, we see that the SSRI exposure is initially associated with multiple psychiatric outcomes beyond the ones that I just showed you today, but the increases are largely accounted for by confounders with the possible exception of GI. In the birth cohort study, we show the pre- and postnatal depression trajectories are better accounting for at least our 2-year outcomes than the SSRI per se. The important take-home messages for me are that the findings do not completely rule out causal effects because these are not clinical trials. There's always going to be unobserved confounding. They also don't suggest that the preclinical findings are not valid because they are in animal models. It's just that in humans, maternal depression is a powerful competing factor that cannot be ignored when you're looking at the effects of SSRI. And then echoing what Dr. Oberlander said, from a clinical point of view, does it matter? If you're a pediatrician, right, and the child is at higher risk for depressive and anxiety or other, you'd want to screen them. If someone comes in with a high fever, you don't ask that what they did last week to give them a fever. Was it condition A or did they go there? You just treat the fever. So whether the SSRI has a biological effect or a proxy effect, it still remains if the mother took an SSRI, the child might be at higher risk. And it warrants closer scrutiny and screening. How much time? Okay, so I'll end with what's next, which is really a wish list, and it's a good transition both to Dr. Stika's talk and then our discussion period later. So one of the things we're trying to do is, we've been talking about, I try to disambiguate the depression part of the story, but we're also looking to see the SSRI part of the story. So we're looking at doses, we're looking at medication equivalent doses, and related to that, right, there's a lot that happens between when the mother takes the pill and what goes into the baby. There's variation in how these are metabolized, the placenta, et cetera, et cetera. And we have some initial data that I'm happy to talk about later showing that there may be differential effects in what goes into the fetus and is documented in the baby's meconium based on which SSRI the mom took. We've also been talking just about SSRIs, but there are a lot of other serotonin-based medication, and there's also natural serotonin, right? And the baby's serotonin system doesn't really emerge till several weeks after gestation starts. So there's some hypotheses shown in preclinical models that during the first couple of weeks, it's the mom's serotonin levels that can define how these thalamocortical circuitries are defined. And the hypothesis there is it could be a direct effect, but more likely they're impacting placental gene expression that then promotes downstream effect in the kid. So we're looking at that in a subsample. And finally, I flipped, I'm sorry, I spoke about them in the wrong order as I had them. The final point is, these are not in a vacuum. Just there's maternal anxiety, which I didn't talk about, and then there's a whole range of psychosocial and environmental factors that also can co-interact with each other and have multiplicative effects. So that's really it for now. These are the collaborators, especially the Danish and the Canadian collaborators highlighted who've done almost all of the work, and then the funding that we've been so lucky to receive. So I'll stop there.